following up on this. Then it is evident that EMR can easily replace the manual registers. There's a lot of money that goes to the printing of manual registers. When changes come up, then we need to think about printing more registers. But with a system, this is something that can just be programmed, and we have the new changes as up. So the healthcare workers also suggested that under the occupation select option, we need to make it open, whereby the provider can type the client's occupation. Then they need to notify the provider when the vital signs are beyond the normal range. That is the pulse rate and BP. We need to have a flag for that. Then when enrolling the client, the system should automatically give the next patient unique ID. Now this is for the new clients. So in terms of our plan on the mass rollout, so we will commence once we get a go ahead from the Palladium group and the other stakeholders. Then we'll continue to develop a county-based, we have 3 counties that need to migrate. So we need to have a work plan for each county because they are unique. So in the mass rollout phase, we plan to first migrate data from a sample of all our environment. For us, a high volume facility, the rest we have is around 2,000 clients in our region. So M&D will train program staff and other stakeholders before we embark on the mass migration. And then we will work closely with our EMR champions to take up the actual migration of the system. Thank you.
Yeah, thank you, Mashira and team. I think you've tried as much as possible with regard to the time available. So I want to be able to encourage us to keep posting questions on chat. But let me find out if there's any one with these steps and CAP who have also gone through the control migration. It's not a presentation, it's just 1 or 2 comments with regard to your experience. CHS Tegemeza, any comment to make a comment?
Yes, Brian. Good
Please
morning.
Go ahead, 1 minute.
Yes, good morning, everyone. I think for Afya Jijini, with the support of Palladium, we tried in one facility, and I think we are comfortable. We are okay with the move, and we should be scaling up very soon.
Thank you for that feedback. You can still continue to engage on chat if you have any questions to Afya Jijini or any other partner who has already presented. Amref, any comment from Amref?
Yes, good morning.
Yes, Ken Gadhu, on behalf of Amref, you have a comment for us?
Yes.
Go ahead, Ken.
I think one of the additional I can maybe put across is whereby the site who are migrating right now to read the assumption document so that they can identify what was happening in IQCare, and it's not, right now it's not happening Kenya EMR, like the issue of the use of TCA while calculating the current on ART. So those are some of the things which is good to run for those who are migrating for the first time, so that to understand it's not using prescription like how IQCare was doing, but right now it's using TCA. So, but all those have been covered in the assumption document, which is a very good document for partners who are migrating for the first time, at least to understand those changes. And also the issue of TO. The TO initially it was happening from the IQCare, it was happening effective from the next TCA, but in Kenya EMR right now, it's effective immediately. So those are some of the areas which has already been put across in the assumption document. And I wish those partners who are migrating for the first time to go through the assumption document so that they can have a clear reflection on those small changes. Thank you.
Yeah, thanks a lot, Ken, for that wonderful contribution. I believe that the partners have heard, and they just need to get their hands onto the document, and they will be good to go as an additional item to consume during this migration. LVCT steps.
Good morning, everyone. My name is Kennedy Uko.
We can hardly hear you, but we are getting some effort from you. Is it possible you adjust and come closer to the mic?
Yes, thank you very much. So my name is Kennedy Uko from LVCT Steps. So
Ken, go ahead.
Allow me to share my screen. Yeah?
Yes, 1 or 2 minutes, Ken, because we are out of time, but go ahead.
Okay. So are you able to see my screen on your hand?
Yes, we can.
Yes, so this is just a presentation on the journey to migration that we undertook in the last last 1 month. So before any SDP think about migration, it's very important to first of all ensure that you have done stakeholder engagement, and also it's very important for you to train the TOTs or the system user before you deploy the system. It's also very important for the people who are undertaking this process to also download the updated migration resources through the SOP to help them proceed with the migration smoothly. And then again, it's also very important for them to upload the datasets for the WAPI QA before and after migration. And then it's also very important for them to run the migration toolkit and conduct some data verifications and data validations on all the indicators. And then it's also good for you to ensure that you have set up a good environment, whether you want to do Windows virtualization using the Docker, or whether you want to install the Ubuntu as a standalone for that server. Then it's also good to, first of all, ensure that you have all the hardware that you will need for you to install this software. So this is how we did our stakeholder engagement. So we sent a communication to the facility in charge, and also we sent a communication to sub-county health record officer, and also the care and treatment technical lead, as well as the M&E team, just to try to explain them why we are doing the control migrations and what we expect from the control migration. So we migrated one facility, that is LVCT Health Manyata Dice. And then before we deploy the system, I think even before we came across doing a control deployment, there was some time back early in February and March, we were doing some data cleaning, and we took all the sites that are using the IQ Care, on how to ensure that they complete the data sets in the IQ Care and also ensure that they have a clean data sets. So during this time, we also try to inform them that we will not migrate any site that has got a poor or a very bad quality data in the warehouse. So actually the sites were even prepared before we conducted this exercise. And then on my side, I also did some personal research on the Kenya EMR, just to understand how Kenya EMR is working, what is all about the Kenya EMR, what is the comparison between these two systems. And then around early June, I did a TOT to 4 facilitators who were supposed to help me during this mass rollout, so that I don't find myself overwhelmed with the work. And I also introduced them to the data warehouse resource page, so that they can be able to get these training materials, and also the YouTube for getting the video tutorials that they can be able to use, and also give the system users. And then after that, we did a training to the system user at that facility. So it was a 2 days, and in the evenings, in the afternoon session was being done by Palladium on the reporting, just to give the sites an idea on how to run the reports on the Kenya EMR. And we managed to train all the HTS counselors or all the clinicians and the reporting officers. This is how we carried out our migration. So we realized that we needed a new desktop with a very good specifications. We never went to buy this, so we had this. We got this from the ICT, and then I downloaded all the migration SOP, the updated ones, and I did some migration on this PC in the office before moving to the sites. So we did some thorough testing with it. So before I started migration, I did I uploaded the data to DWAPI for QA, and then I proceeded with running the migration resources. Then after that, I did some validation on all the indicators using the template that was provided. And then that I went ahead and installed Ubuntu as a standalone, and then install all the required prerequisites, and proceeded to the installation of Kenya EMR, and then running the database as well. And then from there, I did validations, which proved to be 100% based on the assumption document that was given to us. And after the migration, I did some OJT and mentorship to the team. Just try to engage them and put them up to date so that they can be able to understand and familiarize with the system and use it without any challenge. And then again, recently we had we did some check on the report, just trying to run the report and also help them understand the ETL concept in the Kenya EMR. And we did we generated some reports and we compared versus what is in the source document, just to ensure that whatever that they have in the source document is the same as what in the electronic report. And then so far after the migration, we did some OJT to the teams using the Microsoft Teams, and also we supported them using the other application like AnyDesk. Experience during the migration. So the migration was smooth. According to us, we never experienced any challenge, any bugs. We never experienced any bug at all. So to us, it was just, it was working for us well. And we tested everything just the way it was indicated in the documents for migrations. And we are able to understand now when we got the assumption document, we are now able to understand how the two systems were even computing like TX current from both IQK and the Kenya EMR. So this is the feedback that we got from the user after we deployed the system. So the system was deployed in 3rd July, but this IQK was put on hold on 1st July 2020. So the facility, even before migration, they were using IQK as a point of care. And even currently they're using Kenya EMR as a point of care. And when they were using the IQK as a point of the Kenya EMR as a point of care, they were able to learn some of how the system is able to apply the guidelines on the modules. When you are doing the prep modules, you are able to see that you need to meet certain requirements, and this even the testing. So they are able even to see how the guideline is being applied using the EMR, and even they're also able to see whether they are, in case they are doing some mistake, the system is able to inform them, and then they are able to learn and proceed. And then they say that the system is a user-friendly interface, and they pick up well using this system. So they never had, I think the 2 days training was very okay, but again, we will still be able to engage them in more trainings just to make them perfect. And then they also like the air reporting using the ADX. So they say this module is very okay, and they really like to ensure that they have 100% confidence with what is in the paper, so that they start using the air module. And then also the report that was also available from the Kenya EMR module. So this one also, they really liked about this reporting module. And then they also, I think, requested for the IL configuration, so just to be able to pull the VL so that they don't do some entry on the VL, so that they can be able to see and appreciate the benefits of the IL. And then they also love what we call the data security that comes with the Ubuntu as well as the Kenya EMR. And then again, they also like about the password resets that is available in the Kenya EMR. So this is some of the lessons that we learned.
Yeah, thank you, Ken.
Yes.
Is it possible you wrap up within 1 minute?
Yes. So we are out of power, but let me try. Are you able to hear me?
Yes, we can hear you. Just take 1 minute to just summarize high-level things that we need to take note of.
Oh, okay. So we realized that from the lesson learned, we realized that module migration made it easy for the team to review the validation before deployment to the site, and also training the user before deployment is also very important. We also realized that stakeholder engagement is very, very key in any implementation. And then lastly, we realized that the migration toolkit that was updated, it's working. And the other site or the other SDPIP can also use it now to do their migration. And then we now intend to participate in the mass rollout, and we believe that within the next 1 month, or maybe 1 to 2 months, we'll be able to conclude the migration process. Otherwise, I would like to acknowledge the entire Palladium team the support during testing and also during the installation of the Kenya EMR. So she really supported us to ensure that we never experience any difficulty. And then I also like
Kennedy, can you hear us? I think we've lost Ken. Okay, thank you. So I guess we've run out of our time. It was the longest 1 minute summary we've had from this team. So because of time, I will not invite CAP. If they have any comment, they can be able to place it on chat. So let me take this opportunity to thank those who have presented and some of the recommendations they've made for us with regard to migration that we need to be aware of. I hope that some of the slides of your presentation will be made available for everyone so that we can be able to read the finer details in your presentation. Let me take this opportunity to be able to invite Margaret Ndisha from CDC to take us through the next session as presented by Palladium. The floor is yours, Margaret. Palladium, Margaret.
Thanks, Brian. Ndisha is not on the call at the moment. I will stand in for her. She's held up somewhere. So we will move on and request the Palladium team to take us through the next presentation, which is the phase 2 migration and the first wave toolkit. That's in regards to the preparation for mass migration. So Karibu Palladium team.
Good morning, everyone. My name is Diana. I'll be presenting on the first part, the mass migration rollout plans. Someone confirm if you can hear me.
Yes, Diana, we can.
Okay. Right. So my presentation will cover just a little bit of control deployment. I'll skip some of the slides because some of the things have come up in the partners presentation. I really do not want to dilute very good presentations. I'll take us through the site selection criteria. We are looking at this mass rollout phase since we are done with the control deployment. The migration activities, I'll touch on a few. I know most of the activities came up during the partners presentation. Also, I'll take us through the capacity building strategy that we have, and also how we'll support the partners during this phase, and then the way forward. So the reasons why we set up the demonstration sites was just to document the migration process and the lessons learned. I think we've had that from the partners who participated in this. Another reason was to perfect the toolkit before mass rollout. So we've received very good feedback from the sites that were participating in this control deployment. And the feedback has made us to improve the migration toolkit. And the toolkit I'm talking about are not just the scripts, it's also the SOPs and all the training materials. So we really appreciate that. Another one was to just build the stakeholder confidence in the migration process. You've heard from the partners saying that it's doable. We have done it. So that confidence was built when we set up these demonstration sites. Also, it's providing a learning opportunity. I think all of us are learning from the partners who participated on what we need to improve on when we go to mass migration, the steps that we need to take, and such like activities. So for this demonstration sites, this is just a slide to show you all of them. Some partners, because of time, did not get an opportunity to present, but we had 7 partners. That is Naishi, Tegemeza, Kamilisha, Jijini, Amref, LBCT, and the total number of facilities are 10 that participated in this rollout phase. So we started with facilities which had less than 1,000 thereabout, except one active clients. We just wanted to see how the toolkit will behave in these small facilities, pick lessons learned from these facilities, improve the toolkit, and then now we can go to mass rollout. I think from today, we have the confidence, all of us, that the toolkit is working, and we are ready now to go for mass rollout that will go to the other facilities. So the best practices, I don't think I would want to touch on this slide. I think it came out very clearly from the partners' presentation, what the best practices are to be undertaken before the migration. Maybe I'll just touch on one, which maybe did not come out clearly. There's need to upgrade the sites to the latest versions of IQ. So we have the latest version, that's IQCare 2.1 patch 3. So that is the latest version that we'll use. So before migration, make sure you upgrade the sites to that version. So for planning and everything, I think those have come out very clearly in the presentations from the partners, and I wouldn't want to take so much time on that. So for the rollout phases, we have 762 IQCare as per our list, which we'll also share with the partners and also the agencies, just to confirm that we have the right list. So the 10 facilities participated in control deployment. And now we are going to the mass rollout. So when you look at my presentation phase 2, initially we had 541 sites that will be participating in phase 2 rollout. But we have another different process for AFIA mobile sites. So we've set up a different process for AFIA mobile sites. So if you have AFIA mobile sites, kindly hold on. We will give guidance on how to migrate the AFIA mobile sites later. So we will start with the 428 that do not have AFIA mobile in the facilities. So that will be the first facilities to go live. Phase 3, these are sites with sites and partners with customized IQ Care. So we have a total of 136 sites that are in this phase 3. So I've separated so that we can see the difference. Out of the 136, we have 37 sites with AFIA Mobile. So when we remove that from the list, we'll have 99 facilities that will be in phase 3. So phase 3 would be different because we are having different engagements with the different partners with customized versions of IQ Care, so that their rollout plan will be different from the mass rollout because there are some prerequisites that need to be done before the sites migrate. We also have other sets of counties, that's the ASAL counties, that is the arid and semi-arid counties. These are, we have 27 IQ Care sites with no PEPFAR support. So I'm happy that we have UNAIDS in the call. UNAIDS will be, with the support from NASCOP, will be supporting these facilities to migrate to IQ Care. So these ones will also be in this mass rollout phase. Also, we had sites with no partner support. We want to thank USAID for supporting for saying that they'll support the 46 former HCM sites through other partners that are USAID. So we'll only be having 2 sites that were former EGPAV ZUIA that will not have any partners. So we may want to work with NASCOP to ensure that those 2 facilities get the support. So also these sites with no partner support, but I think I'll change that because USAID will be supporting the 46. So like I said, we have 150 sites that are currently using AFIA Mobile. So we have a different plan for migration plan for AFIA Mobile sites. So when I talk about EHTS, I just want to clear this. We have different modes of implementation of EHTS. So for this, I'm talking about the IQ Care sites. So we have sites that are using mobile, that is AFIA Mobile. We have sites that are using mixed. That's a site, some HTS counselors are using the HTS module of IQ Care, and some HTS counselors are using the mobile version. So those also will have to, because there is AFIA Mobile in that, they'll have to wait for the next phase. So then we have other partners with that are using the HTS module only, not using AFIA Mobile. So those sites that are using the HTS module will just transition to KNAMR and they'll continue using the HTS module of KNAMR. So for those sites, they don't have to wait for another phase. So all those sites will be in phase 2. So I hope it's clear. So when I say facilities using AFIA Mobile, I don't mean all facilities that are using EHTS. So EHTS, you can be using the module like some of the AMREF sites, but you migrate, then you continue using the module for KNAMR. So the AFIA Mobile only is the one that will have a different plan for that. So for the site selection criteria, it's the facilities running the Kenya HMIS version of IQ Care. So this is what I'm talking about, the mass migration, this phase 2. It is running the Kenya HMIS version, that is 2.2.1 before the migration. Another thing is, of course, all these are active EMR facilities, they're actively used. Let's keep this in mind. So for the migration activities, I'll very quickly go through this because I think most of this came from the partners' presentation and I don't want to waste so much. Just to mention that we need to be very keen as we pick our site selection, as we do site selection. Engagement of facility and county leadership, I think everyone has talked about. It's very important everyone is on board. And also it would be good to just have a desk migration before you go to the site. And data validation and verification process, very important. We also encourage the partners, the facilities and the partners to migrate data to warehouse. That's before and after the migration. So this is also covered in our SOPs. If we follow the SOPs clearly, I think would be good. Then also post-migration, I think I've mentioned. Training is very key. So Palladium team will be supporting the whether their capacity built so that they can cascade. Reporting it would be good to just for the team to just know where we are. So we would be having a reporting tool so that we can just know at any given point how many facilities have migrated, and also we need to have proper documentation of this migration process. So the capacity building approach will be having a two-tier process with the HIS partner. When I say HIS partner, that's Palladium being the first tier, and then the SDIPs, that's the partners, and the counties being the second tier. So tier one means that Palladium will be taking lead in ensuring that we transfer knowledge and skills to the SDPs. That is on system admin training, migration training, TOT training. So when I say TOT training, that's the system navigation, reporting, all these types of training. And then now the SDPs will be in a position to cascade these trainings to the sub-county facility staff and also the EMR champions. So we've started some engagements and some trainings that we've already done. So we've already done some we've done some TOT trainings on system navigation and reporting. We've also done some trainings on national data house. We've also done some trainings on the migration, but we also have trainings that will be happening. I hope everyone got the invite for today's training that will be happening in the afternoon. So monitoring and technical support. So we'll be using the WAPI EMR metrics to monitor this. That's why we are just urging everyone, if it's possible, kindly upload data before and also after migration. We have an online migration reporting tool, not a long tool, just a very short tool that everyone will just have an idea where we are at any given point during this migration process. If you're asked how many sites have migrated, it would just be good if we update this tool. We'll be sharing this, a very short tool, so it won't take so much of your time. So the issue and reporting and technical support, we want to streamline this so that we just have one process of reporting the issues that come from this migration. So if you encounter any issue and you need support, we have one process which would be the service desk. So service desk would be one stop shop that will be receiving these issues and triaging them and ensure we follow and ticket them. So in monitoring migration, like I mentioned, we'll be sharing the list, the 762 IQ care site list with the partners and agencies just to validate. And then the partners will have a target setting plan, ensuring that they have a plan on how they are going to migrate these sites. I think after this meeting, I think NASCOP will tell us to go ahead. But once we have that go ahead, we can just have that plan to ensure that we migrate all the sites. Submission of final line list targets and work plan, maybe we'll just share how we will share that so that NASCOP, Palladium, and the agencies also are in copy, knowing that these are the partners and these are the sites that are going to be migrated at any particular time. So for the reporting migration progress, like I said, we have a very short online tool which will be submitted through Google Forms. Looking at very few variables, date of migration, any issues you encountered, did you manage to upload data before and after migration. So those are a few things that we just want to monitor, and we are counting on the partners to help us document this. So like I had mentioned, for any challenges during migration, tickets will be documented through the Kenya HMIS service desk. We'll be sharing the links in the follow-up slides. So this slide is just to show the migration technical support. So I'll start from the bottom row. That would be the stakeholders. That would be the SDPs, technical teams, county proximate universities. These are health IT team, and the end users. So at this stage, we will be having all the issues that are coming from the facilities will go straight to the service desk. So you categorize the issues go to service desk for reporting and documentation. Then the issues from service desk will be picked through our software development process. This is where our developers and the assurance team are, so that the issues are just scheduled, and the quality assurance team, after the issues have been resolved, they just test and we have another product release. And then we'll close those tickets once we have a resolution. So the tools that we'll be using for service desk will be, we have the toll-free line. I'll project that in my next slide. And we also have Spiceworks. So that's a ticketing system that will just be following up all the issues to ensure that anything that comes from the migration, it's being prioritized and ensured that we have a resolution for such an issue. So this is a support circle that we just want to adopt in this mass migration, so that we ensure that we just have one line, so that we don't have emails, we don't have some WhatsApp, and so it would be very hard to track the issues. You can still send the issue through email, but first it would have gone through the service desk for ticketing. So how we'll be supporting you, like I mentioned, is service desk. We have that email, that's help@palladiumgroup.spiceworks.com, and the ticket portal up there. And or you can call the service delivery line on the toll free. So you call this number, you're not going to be charged. Palladium will take care of the cost of calling. So thank you, everyone, and thanks the team that participated in the control deployment. You've taught us a lot. You've made us improve the processes. You've made people have confidence in this process. We thank you so much. That would be the end of my presentation. Thank you.
Thank you, Diana, for the presentation. I think it was quite on point. And I think the message to all of us is that we are cutting the ribbon. And Njunge said this at the start of the meeting, that it's time for us to have the mass migration to the remaining sites. And this is because what you have presented, especially for our 9 partners who have already done it, is we have a lot of confidence that we can be able to move on. Now, time is not on our side, so I will request if you have any question, you continue having them on the chat box. And I want to thank the Palladium team, that's Leon and Bernard. They've been able to respond to the already asked questions in regards to the equipment specification, which version of Kenya EMR is going to be in use. And of course, there are others who are asking for you to migrate successively. I mean, KCCB, thanks also for sharing your experience and saying that your migration was successful. So I don't know whether there's any burning question. So 3 questions, sorry, from the team. If anyone has a question, kindly put up your hand. I will ask. And if I do a rundown and find no hand, I will assume that the chat box is sufficient, that we can continue posing our questions there. In the meantime, I would request the care team, who are our partners in this, to give us time, to continue preparing to give us their remarks. As you said initially, all of us here, majority are either in M&D or data management team, but we are doing this for the sake of care and treatment team. So we will have remarks from the care and treatment team led by Dr. Susan Joho from NASCOP. Then we will have Dr. Isabella Yonga from USAID, and Dr. Ken Masamaro was supposed to be part of that team, but unfortunately he did not join the call because of other commitments. So Susan and Isabella, get ready just to give us words from the care and treatment team in support of the migration process. And probably before we proceed, we have one last presentation that is going to be done by the Palladium team as we wait for the questions to continue trickling through the chat box. So I will hand over to, I don't know if it's Dr. Jacob or Diana, to do the last presentation, and then we can proceed with the question and answer session.
Yeah, that will be Patrick. Patrick will release the migration toolkit and just provide a few release notes about the same. Patrick, go ahead.
So good morning, everyone. I will take you through the release notes. Just a minute as I share the release note. There's my screen. So I hope you can all see my screen. So basically the release toolkit for migration is 1.30. We have already done 1.0, 1.1, 1.2. So the release toolkit has a link to the PDI tool. That is the tool used for migration. It has the manuals for the users. It has the transformations for the ETL process. It has the Kenya EMR version 17.11. Please note this version is different from what the rest of the users are using. The reason why we have set a different version for this Kenya EMR is for us to be able to distinguish it during help. When you call help desk, we are able to know you're using the migration package. And there are also some other functions that we have been able to enhance in this version of Kenya EMR. So we have 17.11, please note that. And we will be doing another release to avail these changes to the rest of the community. The release note in this particular version that we have released on Friday, and that will be used from today going forward for the mass migration. We have addressed the issues that were identified during the controlled migration and gradually provided to us by the partners who are doing the controlled migration. One of that was some of the data sets, especially in green card encounters, were missing, like allergies, chronic illness, adverse drug reactions, complaints by patients. So all this has been addressed and fixed in this version. Then there was the issue of ART fast track patients and differentiated care model that was not correctly addressed in the previous versions of the toolkit. We have fixed this and tested it. There was the issue of current on ALT that has also been reported today by the partners who are presenting. There were some discrepancies in the current on ALT and on CTX. We have addressed this, but we have also updated the assumptions document to explain some of the things we have identified. And as said by Amref, we would wish to request the partners to carefully go through the assumptions document to understand these differences. There was also an issue on viral load requested and results dates, which were not well displayed. So we have fixed that to make sure you can know when you requested and when the results were received. Then there was the PHDP observations in the encounters that had not been migrated properly, and we have fixed this. The same for presumed TB in TB screening. There was also another issue about terminating patients who have died in a migrated site. So you could not be able to say a patient has died after when you're using the migration package. We have fixed that. Then there was a mapping of general examination in the green card encounter. Then for facilities that are using programs like OTZ, OVC, HEI, and MCH, there was lack of enrollment data for those clients who are already enrolled. So for instance, if you had an OTZ client enrolled in OTZ, after migration, you find they are not enrolled, and we have been able to fix that. And finally, mapping of stability assessment. If you had done a stability assessment for a client previously, and then you migrate, you should be able to find that assessment existing post-migration. So that is on the release notes. Much of this is available on GitHub in the release for this 1.30 and for the previous releases. So I will go directly to a highlight. This is just a highlight. These are not the only assumptions and decisions you've made. This is just a highlight of the key. And one of them is on the calculation, especially in regard to 731. And I'll try and explain why this difference exists. In IQ Care, you had to prescribe drugs to a client for them to be on current on ART. So the current on ART was a function of the number of days the drugs are dispensed, not the TCA. So in Kenya EMR, TCA is used to calculate current on ART. So to be able to achieve this during migration, we calculated the number of drugs prescribed, and that informed the calculated TCA that went to Kenya EMR to inform the current on ART. Please, so this is a departure from what we were used to in IQ Care, and therefore it's very important that we understand. The second assumption on the calculation was 0 days for current on ART. which also applies to on CTX on the TCA date. So it is 0 days if your prescription ends today, so you are immediately dropped from current on ART. So in IQ Care, drugs were prescribed up to the last day, and this we have learned is why we are having those discrepancies in TXCAL. For instance, if you are reporting on 31st, and in IQ Care you have someone who has drugs ending on 31st, that person is considered as active in IQ Care. But in Kenya EMR, you need to have a visit on that particular day for you to be active. So if today you're reporting today, which is the reporting date, and you have 20 patients who are supposed to come today, IQ Care would have counted them as active, Kenya EMR would drop them. So that's why we are not achieving 100% TXCAL in both systems. So we have also noted that persons with data inconsistencies, like for instance, enrollment date is greater than date of birth, or start date is greater than date of birth, or start date is greater than enrollment date, are not accounted for in the age disaggregation in MOH 731 and DATIM. And therefore, as you're going through the line list, you will find, especially the age disaggregation, some clients will not be there, but the total might be greater than the summation of the age disaggregation. So we have learned this is where this is coming from. And as you can see in the column code assumptions, we are not cleaning any data, we are migrating it as is. So those inconsistencies will exist post-migration. So implication of this assumption is some discrepancies in DHIS reports with DATIM and for TXCAL indicators. TXML will be affected in cases where a patient had a TCA for 1 month, but a prescription for 60 days. They'll be deemed as defaulter in IQ Care if the TCA passes without a visit, but will not be defaulter in Kenya as the calculated TCA is 2 months. Appointment dates or calendar differences between the two systems, like I have explained in regards to the calculated TCA. Defaulter reports, as you can now understand, might be different. Finally, differences are expected where a patient TCA is on the reporting date, whereby in IQ Care they'll be considered active, but in Kenya EMR they will not. I'll move to the next list of assumptions. This is on calculation of age. In IQ tools, age is, for instance, 17 years and X months equates to 17 years. And in Kenya EMR, if you are above 6 months, you are moved to the 18 years. So as you expect in the age disaggregation, by age will vary, but this should not affect the overall sum of the main indicator, just the disaggregation. And this is expected to affect any report that has an age disaggregation indicator, like 731, DATIM, ART, drug report, HTS, register disaggregation on the and MCH related reports. This also affects the way the age appears on the user interface when you actually opening the patient in the system. You'll be able to see a slight difference in the age. In terms of IQ Care, the next assumption or finding was IQ Care treats drug events as dispensed drug, while Kenya EMR treats ordered drugs as drug events. So varied drug events are those that are ordered and dispensed. So that is the assumption. Those events are ordered and not dispensed, are not included in the drug events. So there is expected, and as you know, in the migration, we are not migrating prescriptions that are not dispensed. So the implication is that the drug events that will be reported are only those that were prescribed and dispensed as before migration. Hope that is clear. Then the next assumption is dates for sentinel events like DOB, TCA, all the dates that we have a look at, and they are inconsistent. These I have already mentioned when I was talking about the calculation. So we are not cleaning or verifying, we are just migrating as they are. And therefore the implication is there might be logical or inconsistency. that existed before will still exist post-migration. The next slide on assumptions is on dating. Some patients who are currently active on treatment have a recent viral load in IQQIA. So the reason for this is that there might be expected differences in IQQIA and KNMR dating report. Because IQQIA was including patients who have not been on 3 months on the ART report, but KNMR is not. So there might be that discrepancy in that report. One more observation that we've done that is very widely spread across most of the DBs that we have tested is a UPN, in where we have either some special characters, non-alphanumeric characters in UPNs that do not conform to the standard MOH. This is mostly for facilities with very old data. So KNMR relaxed the rule to accept those numbers as they are arriving during migration. And therefore, these numbers will not conform. Please note, if you want to update a patient who has a number that is not standard, you'll have to fix that number before you are able to update their records. Then second last is that we found some duplicate patients in IQQIA. So we cannot be able to fix that during migration. So that data is left as is and is expected to be fixed in KNMR using the deduplication function to allow you to fix those kind of records. And finally, there are some records that we found who are CCC enrolled clients, but they have no UPNs. So these patients will not be migrated because no patient can exist in a CCC program post-migration without data. This is affecting facilities that have very old records. So if you had done a total count of your patients, there might be data loss post-migration. Finally, these links are very important. When the presentation is provided, you'll be able to access them. The number one link is one we are insisting that everybody familiarizes with the assumptions and decisions document. Then there is a work plan template where you will inform us about your migration work plan. Then the SOPs and training manuals for the migration process. And finally, the toolkit that is available in our GitHub for release. Thank you very much. I think at this juncture, I will invite Jacob to take us through this.
So thanks, Patrick. This is a short session, just one slide that just highlights the plan for the coming week. So the first is the sure that we are working with the same list of sites targeted for migration. And then, of course, the partners will need to schedule their migrations based on their work plan and their resource availability. The next part is on online training. As Diana mentioned, there's already some trainings that are ongoing. So please just make sure you look out for the invites and the scheduling so that your teams can participate. Then there is, of course, sensitization that will be directed at the partners through their respective focal persons from Palladium team on how we will be, reporting on your migration progress, the few indicators that Dan had mentioned, and just to align with you on the use of help desk for reporting and tracking any issues, especially for the first wave of migration. This will be very, very important because there's a lot of learning that will be taking place, and also, new team members using the systems. Then there are system navigation trainings. I know the partners will be doing this directly with their end users, but we also have been having a series of online trainings that can benefit end users who may have internet connectivity at their disposal. The first wave of migration, is targeting non-EHTS facilities, not non-EMR facilities, particularly AFIA Mobile. And as I indicated, we will be communicating as soon as possible on when you can start off these migrations. We do not expect this to take more than 4 weeks. We are working together with Health IT. Health IT will be supporting some partners Possibly, Brian, maybe at some point during the session, we could give them a chance to highlight the counties they'll be supporting. So they'll be available to support some of the partners who will be migrating in some counties. Then, of course, as Patrick indicated, there are certain indicators that were being calculated or computed differently in IQ Care compared to Kenya EMR. We are looking to the Ministry of Health with the agencies to convene meetings where we'll be discussing some of those changes that need to be made so that we reach consensus with everyone. And then we make the priority enhancements to Kenya EMR to accommodate the indicator definitions that are adopted. Finally, it's just the post-migration release of Kenya EMR will be taking place again sometime in August or September. Basically, there are some features that were in IQ Care that you may not have access to in Kenya EMR, even though the data will be available already migrated in Kenya EMR. So we'll be starting a process of making enhancements to include some of these features in Kenya EMR so that we do not disadvantage you through this move to Kenya EMR. So that's basically the summary presentation I wanted to make. I'll give it back to Faith to take us through the next sessions. Over.
So thank you, Palladium team, for the presentation on our next steps in regards to mass migration and the first wave of migration, the facilities that we shall be getting to. And as you have heard, it is a collaborative effort between Palladium and Health IT. Because of time, I don't think we'll be able to give them an opportunity to share the sites that they will be supporting, but I think we will be able to send this out to the respective counties and facilities that shall be supported under Health IT. But we really appreciate the efforts by everyone, and together we shall make it. For those that are doing this for the first time, I believe you have heard from those that have already done it, and it's quite encouraging. And the key word is the assumptions document. Kindly read it well before you begin the process. So because of time, we're supposed to be wrapping up at 10:30. I will take this opportunity to welcome Dr. Susan Jogo, who's the head of care and treatment at NASCOP, to give us her remarks in regards to support of EMR with perspective to care and treatment. So Dr. Susan, I hope you can be able to hear me.
Yeah, I'm here, Faith. So good morning, everyone. So thank you very much for the presentation and also for the great work that has been done. We definitely know that data is very important when it comes to guiding any program for decision making and for programming. So I think we are in the right direction. We have come from far where we had many tools at facility level, and we've come to this level where integration has happened. So for me, and where I see it is that it is a milestone for us, knowing that now our data is integrated, and regardless of the facility, they can be able to use one system. So, and for that, we know that in terms of sustainability, in terms of ownership, I think it enhances that. So really for me, I'm happy about the progress, and also to know that there are plans also to look at the dispensing tool and see how best this can be integrated, so that again, moving forward, we see a facility when they are reporting their active patients, regardless of whether it is MOH 731 or MOH 729, there is concurrence for regardless of the tool in terms of the numbers reported. So for care and treatment, I know that the integration has will really improve data quality, and we are really happy about it as NASCOP. So thank you very much for all that have put a lot of effort in this, have piloted and seen that it is working. So thank you very much for everything. And even as we go to the next step of looking how to bring in the dispensing tools, I believe that we'll still succeed. So thank you very much.
Okay, so thank you very much, Dr. Susan, and I think we take your remarks, and on behalf of the entire team, which is the HIS team, we look forward to supporting the process to ensure that we better our care and treatment services to our patients, because that's the end goal of all what we are doing. So thank you so much, and I will request just Dr. Isabella Yonga from USAID to say hello to the team.
Morning, everybody.
Good morning.
Okay, on behalf of USAID, I think I want to really recognize this session. Peter Yegon and Brian have sort of kept us updated during our team meetings on the processes that have been taking place actually at very high level. Although I'm not part of the M&E or the core HIV care and treatment team, I am actually with you as this process takes place. I want to thank the partners for the work that they've done, for NASCOP, the work that they've done, and the presentations have actually demonstrated the feasibility of migration exercise and the level of teamwork that is actually involved in, right at facility level. So we really recognize that a lot. Of course, some of the processes that were mentioned as you made the presentations were like jargon to me, but again, the outcome was very clear. So that was a good thing. I think what is encouraging is that this system will actually continue to run, or can continue to run without partner support and PEPFAR support. And as one of the partners mentioned, that this is actually the beginning of journey to self-reliance and sustainability, just the way Susan had mentioned. There's been a lot of training that is going on or has been going on. Maybe just a request at some level that maybe there's a sensitization package for some personnel, people who are not partners, or people who are not in M&E, people like me, so that you can just think about it. I noted that you mentioned that, hey, the MCH, OTZ was mentioned. And for me, being a PMTCT focal person, I'm really waiting for the package for the module on PMTCT, maybe to be incorporated in all this, because some of the things, the high MTCT rate that, again, thank you very much for all the work that has been done. Over.
Thank you, Isabel. Beautiful remarks, and I think it's happy to have the care and treatment team on board, and you will continue to be part of this process so that you can also get to see what the outcome is like at the end of it all. We take note of the request to have the PMTCT module. I believe it's ready, just that you put on hold first in terms of implementation until we are done with migration. But once that is done, we shall improve the existing Kenya EMR to make sure that it contains all the necessary modules. Otherwise, the module is ready for use to be up and running once migration has taken place. So, so that we close out on this, I will welcome the SIITT co-chairs. I don't know whether Evelyn Mudhama is on board. And if Evelyn is not on board, I will request Brian to give his closing remarks before we hand it over to the CIRI team lead, that is Dr. Oramisi, who's going to cut the ribbon for us. I don't know how she's gonna do that, so that she can bless the mass migration journey that begins today. So Brian, over to you for remarks on behalf of the SIITT, but I don't know if Kate Mbaire is also on the call. She could also have her remarks before we wrap up. Over to you, Brian.
Yes, let me thank everyone for the wonderful presentation and also what is going on at all levels. Truly, there is already demonstration of commitment, and there is need for us to just remain committed until the end. I think on behalf of the SIITT, our work is just to be able to ensure that we support you with some of the decisions you need to make. And I believe that at both technical working group level and even the SIITT level, some of the things that we need to make clear, like now issues around indicator definitions and harmonizations of so that systems are consistent and data is consistent across all systems, from regardless of the places where they are reported. So I do believe that, of course, through the support of NASCO, the technical working groups will continue meeting to be able to discuss these issues that will be able to help even these systems work efficiently and produce quality data for decision making. So on behalf of the ITT, I think we are looking forward to more invites for us to be able to provide our input. But I think individually within each agency's service delivery partners continue working with us to be able to ensure that you have the necessary support to fulfill your migration plan, possibly before the end of this COP, and possibly some that will spill over in the next COP. Otherwise, thank you for everything and have a wonderful day. I'm not closing this meeting. I'm just wishing you a nice day because I might not talk again, and to hand it over to Faith. Kate, are you in? I'm not sure if Kate is in, but let me give her a chance if she's in. I think over to you, Faith.
Okay, so thank you, Brian, for the remarks. And I think the word from all of us is that we are behind this and we are really supporting the system. And this far we have made it because of the teamwork. So on behalf of the EMR Migration Committee, I want to thank all of you for the efforts that you have done this far. And we are still out here to guide you. So reach out to the team whenever there is need. And as we begin the tougher part of the journey, I believe we will need to be more cohesive so that we can be able to share our experiences. Kindly, as you start the migration, read and document the process, because through that we can be able to make reference for future use. And I think I am happy to say we could be among the first countries to share our experience. And so it is something worth documenting for sharing in future. And I want to thank you all again, and I want to hand over this session to Dr. Oramisi to give her closing remarks as she blesses us for the mass migration. Over to you, Dr. Oramisi.
Gary, thank you very much. And I would just like to take this opportunity to really appreciate the whole team for your presence during this meeting and for your support throughout the whole process. I want to just maybe answer just a few of the questions that were asked during the meeting, and maybe as we go towards the conclusion. One of the things is a request for us to work on a sensitization package for the people who are not currently in SI. Yes, that is really, really appreciated and noted, because most of this is really jargon if you're not an M&E person. And this is noted and it will be worked on so that we can be able to walk this journey together. And we really want to appreciate the care and treatment team that has really supported the whole process, because, you know, as the M&E team, we are monitoring, but then the actual work is mainly done by our colleagues from the care and treatment team. And we want to appreciate the fact that you have really taken your time to be together with us and to join us. So the new package also, maybe just to update, has many more modules, including pre-exposure prophylaxis, apart from the PMTCT module. And these new modules are one of the reasons why people really need to migrate, so that we can be able now to utilize, and we can also now be able to monitor, because it will really be good for us to start monitoring and giving you data from National Data Warehouse on how we are progressing as a country. I know EMTCT rate, reducing it is one of our major goals as a country, and we are all focused towards it. And we are committed as the SI team to ensure that we are able to track this and monitor and give data. So during migration, we will be able to showcase how these modules are being utilized, and I know it's a lot of work on our end. So currently, as our colleagues had said, is that we just migrate the data as it is. But in Kenya EMR, we are going to ensure that the now going forward data quality checks, you know, those validation rules are put in place so that maybe, for example, a use of 10-digit CCC number is enforced and we are able to utilize it. But just for the purposes of migration and having the data on Kenya EMR, these are some of the things and some of the rules that our colleagues already highlighted that we are going to have them relaxed a bit. But once we have migrated, then we are going to tighten some of these rules so that we can now start having quality data going forward for the country, because you understand the importance of having quality data. Otherwise, from the leadership from NASCOP, it is asanteni sana to all of us, our partners, PCO, UCDC, USID, DOD, you know, UNAIDS, all of us for having participated in this journey. So today we start the big process, which is now the mass migration. We are happy that we have been able to successfully undertake the controlled migration, which at first we were wondering whether we will actually be able to do it, but we are so happy, and we are very happy that the process was actually successful. And thank you, Palladium team. And we know that we still have a big task ahead of us, and we started today. So Faith and team, I don't know where the ribbon is. I can't see the ribbon. But those who can see the ribbon, I am now cutting the ribbon. This is the beauty of having echo sessions. You can't see me, but I can see the ribbon. So the ribbon is now cut. I have cut the ribbon. So we now successfully launch mass migration. We can have a clap. People can just open their mics and just clap. Mass migration. Thank you. So thank you, colleagues. And we will now end with a word of prayer. Mass migration has officially been launched, and we will keep giving updates on how the process is ongoing. And we know that we will be together as we continue with this process. So I will now request that we have the closing prayer. Faith, we usually have another pastor from Palladium team. I don't know if he has logged in today. Or we can ask Dr. Jacob Odhiambo to end with a word of prayer. Dr. Odhiambo, today is your day.
Okay, let's pray. Almighty God, thank you for this day, for the nice weather out there, for the session we have had in the last few hours. I want to thank you for the journey from where you started us to date, and pray that you guide us through the rest of the journey towards completion of the migration process for the benefit of Kenyans. I want to thank you, I want to ask you, Lord, that you take care of everyone in the call and the Kenyans in general. They stay healthy through the difficult time that we are going through right now. I'd like to pray, believing and trusting in the name of Jesus Christ our Lord. Amen.
Amen. Thank you so much. And please let's start. I know Palladium will be there to support us, and as they have done, and they will continue supporting throughout the whole process. Just reach out at any time. We are available to support and ensure a smooth process. God bless you all and have a lovely day. And goodbye from all of us.
Goodbye.
Bye. Goodbye. Thank you.
Bye. Bye.
Bye-bye.
Bye-bye.
Yeah, Pascal wasn't on the call.
Bye. So I need to end the call.